So our presenter today is Sarah Pandulo. She's a critical care nurse specialist. She's also a clinical education specialist and critical care nurse at Unity Point Health Des Moines. Sarah earned a BSN and MSN as a clinical nurse specialist from the University of Southern Indiana. She holds a license as an advanced registered nurse practitioner, certified clinical nurse specialist, and registered nurse. She has presented numerous educational programs throughout her career, such as Recognition, Resuscitation, and Recovery, What is New in Sepsis Management. She is the co-author of a journal article from the Journal of Critical Care titled Time for Critically Ill Patients to Regain Mobility After Mobilization in Intensive Care Unit and Transition to General Patient Floor. Let's welcome Sarah.
Hi, I'm Sarah, and I'm interactive, fun. This is kind of, let's make this fun time here. Sepsis. You know, we all sit there and we go, oh, we know sepsis, but sepsis is something that sneaks up on us. Sepsis is something that we probably have a lot more people experiencing sepsis than we even realize. As they say, you know, majority of people that develop sepsis in the hospital, 80% of them probably had it at point of entry. But you know, nobody comes in and goes, septic, you know, and I said it would be great if they did. But this is something that I have a passion about, and you'll see in a moment why my passion. But this is just some of the objectives, describe some protocols, recognize signs and symptoms, and state, you know like what that delay means, that there are time parameters, and they are very important because of what is going on in sepsis itself. One of the things, this is from 1904, and this really sums up, because the thing about sepsis is, you know, a lot of times when people finally come to the hospital, they're not coming because, they're coming usually they've gone to their doctor, they've tried something, and now they're coming because they can't do it at home anymore. So a lot of times it's no longer the infection. You may not find that, but it's what the infection has done too. It's the infection acting at the cellular level. And I have not been able, in 25 years in critical care, I have not been able to look into someone yet and figure out if they're getting oxygen to those cells. I'm figuring it out. I'm going to get some x-ray vision or something. I don't know. But you know, there's really, you know, if they have obvious signs, like they're purple from the nipple line down, we can all go, yeah, they're not doing too well. But, you know, if they're just coming in and saying, hi, I don't feel good, I'm dehydrated, you know, I haven't really been able to eat, what got them there? That's the thing where we have to kind of step back and say, could this be sepsis? And we have, you know, keep that in our mind, because the fact of the matter is, it sneaks up. And it was first diagnosed in the 700 BCE. The Greeks, go Greeks, they recognized it, stating that, you know, they called it life-threatening condition. They described it as rot. And you know, in a way, it is, when we get through, it is, basically the body is decomposing. And you know, they were pretty much ahead of their time, but gosh, that's 700, you know, that's great. And we're still struggling with this. And now the big thing is, when we talk about sepsis, the really big thing that comes out, there's a lot of sepsis. There's a Sepsis Alliance, there's the sepsis.org. Do you guys know what September is? Yeah, worldwide sepsis. Do you know what September 13th is? Yes, very good. You can have my phone. I don't have candy, that's all I have. I normally have candy in my office. But yes, it is Worldwide Sepsis Day. I have a good friend that passed away with breast cancer. I do breast cancer walks every day. Not every day, but every year. Never have done a sepsis walk. I'm trying to get Unity Point this year. We rounded at downtown at the 3 hospitals on Sepsis Day to do a little case study with people and get them going. And my goal is next year that Unity Point Health will host some kind of a sepsis event, because it's out there. You know, I was reading a survey and they were talking about, they surveyed parents, and 41% of parents said that their child could only get sepsis in a hospital. and 90% of children get sepsis in the community. You know, I just thinking they're like mosquito bites. I mean, have you seen how those mosquitoes are leaving those mega and they're like all red and crack, you know? Yep, falls. They pick up things and eat things, and they have siblings that like to eat things. Well, some people that have something in common, sepsis. This is one of the reasons why I am passionate about sepsis. I started in the critical care many years ago. In '97, I lost my dad. My dad was my inspiration. He was a physician, and I lost him. My mom was a nurse, and in '98, my mom had a liver transplant because she had NASH. She got her liver transplant, did great. In 2003, you know, the Prograf shut her kidneys down. They found, you know, that whole circus. So she went on dialysis, which she hated. She would tell you, it's the death of me, you know, and it's like, she was a feisty. My parents were Lucy and Ricky. My dad was from Italy, born and raised. My mom was New York. So anyway, she had this, and due to some unforeseen circumstances and some little, we'll just say little errors, she ended up suffering a stroke. And this woman went from me, I mean, I'm not even half the live that my mom could be, you know, and she went from this woman to bedbound. And she ended up developing a septic. She developed a decube, which became septic, and at another hospital, and my mom passed away in my critical care unit in December of 2004. Before that, sepsis was my thing. I always, you know, everybody's like, give me the level 1 trauma. I'm like, I don't want that. They're like, give me the cabbages and give me the hearts. And I'm like, I don't like those things. And then they're like, oh, neuro. I'm like, keep your neuro. I'm like, I like the sepsis because it was playing like CSI. You know, it's like, and I really felt like I could use all my abilities that God had given me to take on nursing. The other people here is the Pope. When Pope John Paul II, he died, you know, they said complications. It was a sepsis complication. Christopher Reeve, remember, it was quad. He had a septic decube that was not shared with individuals, but that's what he died from. Patty Duke, she was the first person that they actually mentioned sepsis publicly. They actually said, hey, maybe it could be. Muhammad Ali, do you remember? They actually started talking about sepsis because Muhammad had that like Parkinsonians from getting beat up all the time, and he would aspirate, and when he came from wherever his little house that he was getting helped at, they questioned if EMS had a sepsis, you know, was able to identify sepsis and start treatment, would it have helped him? And then, do you guys remember the little girl, Heather O'Rourke, that was in Poltergeist? They're here. She, sepsis, but we never heard that. This little boy is Rory. He's from New York, 12-year-old. He was going, and Hickey from Kanicki's like a Hallmark card. Casey Kasem. But what happened with Rory was a 12-year-old, and he, playing in gym in New York City, slid across it. Wooden gym. Cut his arm, right? We've all done that, right? Cut our arms. They cleaned it up, put a Band-Aid on it, sent him home. So he gets home, and he's sleeping. He's having a hard time sleeping. He gets up multiple times, goes into his parents'. He's got a temp of like 102.3. He's saying his legs are achy. He's got a stomach ache. Well, what was going around? It's March. So they go, probably has the flu. By the next day, Rory's not feeling good, so they decide to take him to his pediatrician, whose clinic is right next to the hospital. And they go in, they draw some labs, and they're like, well, why don't you take him over to the ED and let them give him some fluid, because he's pretty dehydrated. So he gets some fluid, Rory perks up. He goes home. By that time, his labs come back. He has a white blood cell count of 59,000. By the time they're able to contact Rory, is already gone, and he's down his way to septic shock. He's already coded at home. He's on his way back into the hospital. He died 3 days later. And so from that, legislation was actually put in place in New York State that anybody that entered an ED, no matter what age they were, they would be screened for sepsis. No matter what they came in with, they would be seeing if this child had, if they had sepsis. And then they also have Rory's regulations, which they actually have taken sepsis and they mandated that it will be part of the public school system education. And they're really working on trying to prevent this. His mom and dad are very active and they're really working on trying to prevent this to happen. I don't know if you've seen, I think it was about 2 months ago, the People magazine, they actually talked about Rory. So People magazine had sepsis in it, was talking about sepsis. So there's a couple factoids. It's septic shock, most expensive diagnosis, but that shouldn't be what causes us to treat, right, and prevent. Why is it so expensive? Well, continuous renal replacement therapy, they need ventilation, they're gonna have vasopressors, they're gonna have procedures done because we need to figure out what's their source, especially if it's an abscess or something. Survival rates, we've improved survival rates with early identification and supportive care measures, but mortality and morbidity are still high. Mortality for sepsis, just sepsis, is probably about 20 to 30%. For severe sepsis, it's up to 40 to about 60. That's a lot. And, and thinking about these people when they come in, if they're already to that, they're already sick, their mortality is it's not like going and having an open heart surgery and them saying you have a 2% chance of having a stroke. They could already be to a 50% chance of mortality by the time we even touch base with them, because they're already experiencing organ. They say every time an organ goes down, it increases their mortality by 20%. So they could be experiencing, they can be in trouble, and we may not even know it because they're not, they're just saying, maybe I'm just kind of tired. I don't feel good. And then all of a sudden you walk in and like 5 minutes later they went whoop, and then we're all like, yeah, they're not good. I'm sure you guys have watched that person in front of you just, talking, and then all of a sudden, full blown, they're not talking to you anymore. The thing about sepsis is, like with breast cancer, they do have the genetic part. We do have some genetic part with different cancers and stuff. But sepsis, it's based on all of us, and each one of our makeups are different. So it is so hard. We don't have a thing that says, I can do this. We can do a lactic acid, and it can be elevated. We know lactic acid is elevated for other things, so it's something that helps us to rule out. When we know that they're septic, we can use it to help monitor our treatment. But prior to that, it's not only for sepsis. Your WBCs, they can be elevated. Hopefully they're not in the 60,000, but they can be elevated. There can be other reasons. But the thing about it is there's not one thing that says, hey, look at me, I'm septic. Like we can find for other things. So one of the examples that it's like, if we sat all here and decided to become blood brothers, blood sisters, remember, and you slit each other's hands with a rusty knife, and then we all got blood brothers, which one of us is going to get sepsis? We don't know. And who are we going to pick in the room to get sepsis? There you go. Now comes the thinking. Everybody's looking around going, oh. So originally when sepsis came out, they did these definitions. These were in 1991 and 2000, and we had SIRS. Everybody remembers SIRS, Systemic Inflammatory Response Syndrome. Sepsis, they said, was SIRS plus a presumed or confirmed infection. And then severe sepsis was sepsis plus greater than one or more signs of organ failure. And then septic shock was severe sepsis with hypotension refractory to fluid resuscitation. So they said, we now have some advances in microbiology, so we can come up with new definitions. So the European Society and the Society of Critical Care Medicine, they got together and they came out with these new definitions. So here comes sepsis. If you notice, there's no longer severe sepsis. We just have sepsis and we have septic shock. So sepsis, they're saying now, is a life-threatening organ dysfunction due to a dysregulated host response to an infection. So basically, it's saying you get an infection and your body just goes a little crazy in there, and then you're going to have all this life-threatening organ dysfunction. The criteria, this is greater than, this is how they developed this. This SOFA is a sequential organ function assessment. It's something that some critical cares will do it when they come. It's based on like different lab values. The other thing is they came up because they said SIRS is no longer good enough in this. If you notice, they removed SIRS because they said SIRS just doesn't mean infection. Which SIRS can be burns, SIRS can be people after a AAA repair, cabbages can develop SIRS. But they said, no, we don't need that. By just putting SIRS in there, we're saying SIRS is always related to this infection. So they came up and they said, okay, well, here's this Q-SOFA we're going to use for the bedside clinician. But the thing about Q-SOFA is they found out it is good at predicting mortality. If somebody has 2 or more of them, they're probably going to end up in a critical care, and it's good to predict mortality if you don't treat it. But it's not sensitive to sepsis. And then they've now coming out saying, you know, SIRS is kind of at least a little bit sensitive, and it gives our clinicians a place to start. It at least said when they have those signs and they can take these 2 things, it at least gives that person that's coming in first contact go, okay, something's not right here. And no matter what, like we say, we don't like people in the adult world to have heart rates greater than 100. We need to find out, is it simple pain? Is it a rhythm issue? You know, we say, okay, we might get rate control, and then we worry about rhythm. You know, we investigate different things. Their WBCs go up, oh, that's okay. We don't do that, you know, we just don't, it gives us something to hold, you know, something to look at and say, okay, now we need to go backwards and we need to figure out. And then they came out with septic shock, and look at septic shock. This is saying that you have an underlying circulatory, cellular, metabolic abnormalities, and it's a greater risk of mortality. So these patients are identified as patients that have clinical criteria of hypotension, hypoperfusion. They require vasopressors to maintain their mean greater than 65 or greater, and then they have a serum lactic level greater than 2 after they had adequate resuscitation. And so how do we know they had adequate resuscitation? Well, there's a lot of things there. You know, people say we used to do a lot of the static things, CDPs. We'd look at urine output, different things, but now there's all like, one of the big things is the passive leg raise. Passive leg raise. We had a good old cardiothoracic surgeon many years ago, and he wouldn't put a swan in, and you go, well, how am I going to know if my patient needs fluid or anything? He goes, I'm going to teach you. And he was doing passive leg raises. And what you do is you watch, you put them up, you have to do it, and you hold it up, and if you watch their pressure, it's great if they have an art line, you know, because you can see it go up, and it tells you if it goes up by like 10%, they're going to be responsive to fluid. They need fluid. So, because what happened is, I can tell you guys, when I started, we had a trauma surgeon, and he used to like to make people ticks. And they did a lot of our sepsis people too. And I will never forget, I gave one guy 22 liters in an 8-hour period. And he had maybe 100 mils out in urine. I mean, he was like huge, you know, and we just would keep giving him fluid. We didn't have an end point. Because all we know is what goes on in sepsis, we have to kind of bridge them, keep them, getting them perfused, and then the body has to fix itself. And so we didn't know where to stop. Well, now it's a little better because we don't flog as much, but they're really looking at, okay, you give them their 30 mils per kilogram, but we need to know when the end point. Do we just keep putting fluid at them? Because we know the tank has to be filled before we start putting pressors on. We want to make sure the tank, and fluid is important, and you know, it's like, oh, but what if they have heart failure? What if they have this? You know, the fluid, and I'll show you, the fluid is very important that you can accommodate for the heart. You know, like I have an algorithm here that basically, you know, if you got to tube them, and protect their airway, because they need to perfuse. So one thing that came out, you know, you guys know, are you aware CMS is involved in this whole sepsis thing now? They are looking at different criteria about this. Well, they haven't adopted these new definitions. Unity Point Health said, you know, we're not really going to adopt them. But we can use them to our advantage. So we still are using the SIRS criteria. We're still using sepsis. Yes, we're still using, yeah, as you know, but actually we got to give our bedside clinicians something, you know, because there's really, you know, because these people could be, you know, look at, what do we all know? Remember the old lady that comes in and she's confused. So what are you guys thinking? Yeah. Well, why? We don't, you know, they don't know. Is the confusion due to perfusion issue? Is the confusion due to, you know, that she's her age and all that, now she's not healthy, you know, but we need something that's going to identify it. So like the Quick SOFA, it takes into consideration 3 things: mental status change. It says mental status change. It is respiratory rate greater than 20, and systolic blood pressure less than, I believe it's 100. That one's 100. So it's giving us something there that, hey, you do this, and then like take a moment and say, could this be? Because, so I just,
Sarah,
oh,
question.
yes.
So you're saying that kid in New York, if this would have been known, that would have been...
They said they believed, the doctors that got this patient into the critical care believed that even if that pediatrician had done some kind of a screen or had just knew something about and triggered, that he probably would not have ended up. His, you know, life would have not ended. And that's what his parents really are pushing for. Because, I mean, he was gone in 3 days, and he was a healthy 12-year-old kid. He was actually 12. They said he was like 5'7", and almost like 180 pounds. So he was a big kid. He wasn't like a frail, sickly kid. And so, yeah, they felt that if they had identified him here, that he may have not ended up where he ended up. Now, the one thing is mortality is high, but also morbidity is high. So especially with kids, you know, there's another little he had sepsis at 4 years old, and he survived, but he lost arms and he lost limbs, all 4 limbs. So, but, you know, he's now playing lacrosse and all that fun stuff, and he has active with his brothers, and so he's going on with life. But yes, it can become, you know, especially if you think about an infant, you know, like I have a case study that an infant came in, you know, born and started developing fevers. They thought meningitis started, but they sent them home on day 3. By day 19, this baby comes back in, lost weight, and this baby, by the time it spends 10 weeks in the NICU, leaves and had seizures now, so is now on seizure meds, requiring G-tube feedings, on home O2, and I think that was it. And so then anyway, a year later, this was a healthy baby, a year later still not developmentally, not able to walk, not able to hold up their head, you know, so that's a big thing now. You're going all their life. So surviving sepsis was, I just kind of touch base here. This was something that was done because people, we understand we do not know sepsis. We understand we have to get to know this. We need to figure out how do we make sure that we're treating this, because our mortality is still high. And what's happening? People are living longer. You know, think about it. You know, think about this. My mom was a double transplant. You know, wow. That wouldn't have been, I have a niece that was born at 23 weeks. We could see through her skin, and she's 10 now. You know, 5 years before, she may have not even made it. I mean, just thinking of people, you know, grandparents, you know, like, you know, we hear people, I mean, we're getting 90 to 93-year-olds in the critical care unit. I mean, one day we had 4 of them. It's like, wow, someone must have been walking through the nursing home or something. They're like, they're recruiting. We do put down when they say they're going to just start doing open hearts on them. It's like, oh, come on. Why put them through that? They probably have a better quality of life the other way. But this is, so surviving sepsis came back because we had to build awareness, we had to get improved diagnosis. And they came out first in the 2000s, and they put out the guidelines. And they put out, the last guidelines they put out were in 2016. And basically what those guidelines do is they say, do this, because years ago we used to give Solu-Medrol to septic patients. And then it's like, it's probably not everybody. Then we used to give, what's that? Oh.
There's a book.
Yeah, and then we used to go and we used to give, we used to do dopamine. It's Levophed now. How many people remember Levophed, leave them dead? And now we start with Levophed. So we have people that come in that are nurses and medical, and you have Levophed going, and they're going, no, that's the last ditch effort. It's like, no, your family member's doing great. They're on Levophed, and they're like, they're supposed to be gone, close to death with that. So, things change. So, biggest thing, what is sepsis? Sepsis, bacterial infection, but it can be viral. And it can be even a parasitic source. A lot of times we hear people, oh, it's viral, we can't do anything about it. And then they may not, they sit there and little kids, they have viruses, they take them, there's nothing, they're not going to get an antibiotic. But sometimes the parents are like, oh, they don't need, they know they have viral. They know they're sick. And then all of a sudden baby comes in because they're respiratory. I just had a great nephew that they did. They go, oh, it's only viral. And I'm like, yeah, that's not normal. That child is like this, and ended up in the PICU on BiPAP. I said, that's not a normal, that virus did something else on him. So what happens in sepsis? Well, we get an infection. It can be on your toe, it can be on your finger. How many of you guys have put this foam on your hands and go, oh God, when did I get that cut? Because it's like, ow. And so we get them all the time. Yeah, she's like, yeah, we get them all the time. I'm like, well, and I'm there. I just had my knee replaced in April, and so I'm sitting here and I'm going, it's a little tender, and I go, oh gosh, I'm going, is it warm? I said, might be warm. I said, did I open it? I'm looking at the bottom of this. I go, that looks a little strange. Did I puncture it or something? So I'm like, I don't want to get a septic knee. And, but basically one of the ways that I learned this and it was described to me is sepsis is like Girls Gone Wild. Remember those old Girls Gone Wild things? It's basically you have a pro-inflammatory response and then you have an anti-inflammatory mediators and they collide. And what happens is, you get all this, you get this cut here, and we know we have this system that's trying to localize it. And so we get all our cells, we get platelets, everything's going to stop that. But all of a sudden, those things that are going on, there's the mediators, they cause damage to the endothelial cells. So, of the vessels. So our vessels begin to leak. Capillaries begin to leak. So what happens with all these chemicals and everything fighting is we get this vasodilation, we get leaky capillaries, leaky vessels, and then we get coagulopathies on top of it. So in small places, like in your fingers and your nose tips and that, they could be throwing clots. And then, they're breaking down clots in other places. So it becomes the big thing about this is as time sensitive as an MI, guys, as a stroke. We had that all embedded in our head. If I stood here and started rubbing my chest, I'm sure about going, do we need to take you up and do some troponins and get some EKG? If I came in and I'm like, this doesn't feel good. We've all seen that person at the mall doing this and we all walk that way, they go that way, It's like... but if I came in slurring my speech, we know time is tissue. Same thing with sepsis. Sepsis is a perfusion issue. It is a perfusion issue. It is a tissue. Tissue is dying. Cells are dying. Tissue is dying. And I will show you, so I have a little video so you can see the sepsis perfusion issue. But I gotta get my big butt out of the way. This is, I think, I can't remember what this one is. Oh, recommend. Finish. Oh, volume. Do we have a volume?
Bottom right.
There it is. But can I hear it? This is just a nice, quick summary. I just. I'll be a broken bone maybe over here. So if you look at that picture, that's a pretty gross body. But you know, that could be that's basically what's going on. I mean, they're just, you know, their organs are just dying. This is a little pathophysiology of sepsis. Normally, pathophysiology of infection, normally you get the infection, we invaders, immune response, white blood cells attack. They get vasodilation, we get increased capillary because we want to get things there. WBCs come, infections contained, removed, tissue integrity is restored, body goes back. But for in sepsis, it starts here. Something goes wrong with this immune response, and this increased this vasodilation, and these don't go away. They just become more. They become more worse. I was like saying, like I'm a 5-year-old. This is the one I talked about with the, so this is just a healthy, normal, underneath their tongue. So if you notice, you can't really see. This is the vessel, it's flowing. We can't see individual components. We're not seeing much. I mean, it looks normal, right? They taught me blue is vein, and you can't see the red, but I know on my skin, blue is vein because it's got blue blood in it. Wasn't that when you were little? You know? It's got that blue blood in it, so that's why it's blue. So this guy is just, he's a chillin'. Now here's what happens in septic shock. Do you see why this is a perfusion issue? Does everybody see the vessel, the cells now? It's chunky. So do you think we're getting adequate, this is in the tongue, under the tongue. Do you think we're getting adequate tissue perfusion to our kidneys and all that? So this is what happens, the body's unable to recover, isn't he cute? From the infectious process, you get pathological inflammations, you get your SIRS response, and then you get these cytokines. There was originally a lot of treatment was based on the cytokines that were these cytokines that if we started like early continuous replacement dialysis on them, we could remove these and perhaps not go through the whole sepsis cascade. That's kind of moved away. There was a thing like start that early, and now it's going back, does early really do much? Because when you do that, sepsis, as you saw how clotty that blood is, all it does, it just keeps clotting off your filter and it goes down constant. So you probably are not doing it as quick and getting it out there. And here's my little friend. I like the videos. I just, it kind of helps to put some, this just shows what happens to the, that'd be nice if that's what our body's like. I think mine is. Mine's playing opera music inside. I'm gonna eat you. And now we start to get the breaks.
It's a little sunburn, isn't it?
So basically, it's just this normal response, and then it goes, it gives you the epithelials, and you get dysfunction. Goodbye, mister. So here, as you can see, now that's a lot worse than what we had. Looks like little people. So there you get your fibrin clot. So now that is, it's just a lot of mess going on in there. So as I said, sepsis, tissue oxygenation, and this is a thing, because sometimes, and we talk, you know, when we're talking about SIRS, especially new, I'm not sure you guys seeing a lot of new nurses at the bedside yet, or are you getting a lot of newer nurses? A lot of people wait for these to get, they wait for vital signs. Remember we used to wait if someone's vital signs and we're going, oh, they're having pain, and it's like, that's a late sign. They can have tissue hypoxia and still have a normal body, because what? Our body's gonna try and compensate for us. Right? Think of the little kid. Little kid's heart rate is already in the hundreds. They can go up to 160. And they don't have the reserve like the adult where we could go, but they're gonna go up, and so that's why it's like looking at that SIRS criteria gives them something.